management of arthritis. Before going to the cases, let us see what do you mean by arthritis, which includes rheumatoid arthritis, osteoarthritis, and gouty arthritis. First, we will discuss about the rheumatoid arthritis in brief, and then we will landing to the exact cases. This arthritis you already studied in your previous year block of musculoskeletal system. Just I will review the drugs which are used in the management of rheumatoid arthritis and the cases. Rheumatoid arthritis is a chronic systemic inflammatory disorder characterized by potentially deforming polyarthritis. Polyarthritis, it means there is an involvement of more than two joints, swollen and tender joints of the hands and the feet, and also involves multiple organ systems including pleuropulmonary, cardiovascular, ophthalmic, and the connective tissue involvement. The systemic inflammation of rheumatoid arthritis leads to joint destruction, disability, and premature death. The onset of rheumatoid arthritis typically occurs between third and fourth decades of the life. And the cause of rheumatoid arthritis involves many factors, including genetic susceptibility, environmental influences, advancing age, cigarette smoking, and also immune factors. The clinical presentation includes some non-specific symptoms, include fatigue, malaise, diffuse musculoskeletal pain, morning stiffness, and the progressive disease characterized by irreversible joint deformities. The drugs which are used in the management of the rheumatoid arthritis include DMARDs, DMARDs. DMARDs, that is disease modifying anti-rheumatic drug. As the name indicate, they modifies the disease modifying anti-rheumatic drugs. And this DMARD should be initiated in all patients with rheumatoid arthritis. Why? To minimize the loss of joint integrity and function, and to reduce the risk of cardiovascular disease related to rheumatoid arthritis. So disease modifying anti-rheumatic drugs, that is DMARD, should be initiated in all patients. Which are the types of the DMARDs? There are three subtypes of the DMARDs. The first one is conventional synthetic DMARDs, which is called CS, conventional synthetic DMARDs. Their onset is generally slow, and commonly used conventional synthetic DMARDs include methotrexate, leflunomide, hydroxychloroquine, and sulfasalazine, available as oral formulations. Less commonly used conventional synthetic DMARDs include minocycline, gold compounds, azathioprine, and D-penicillamines. So most commonly used are methotrexate, leflunomide, hydroxychloroquine, and sulfasalazine. Targeted synthetic DMARDs include tofacitinib, which is available orally, and biological DMARDs, which is generally monoclonal antibodies given by subcutaneous or intravenous route. So these are the treatment for the rheumatoid arthritis, which includes the DMARDs: conventional synthetic DMARDs, targeted synthetic DMARDs, and biological DMARDs. The first choice with all RA patient is conventional synthetic DMARDs. The biological DMARDs includes TNF alpha blocking agent, tumor necrosis factor alpha blocking agents. These are the monoclonal antibodies, that is the MABs. MABs means monoclonal antibodies. And examples are adalimumab, certolizumab, pegol is polyethylene glycol, golimumab, and also include etanercept, abatacept, which all inhibits the TNF alpha. Other biological agents include anakinra, which is interleukin 1 receptor blocker, anakinra, tocilizumab, which is interleukin 6 receptor blocker, and rituximab, which is monoclonal antibodies and binds to the antigen CD20 beta cells. So these are the drugs which are used in the management of rheumatoid arthritis. Let us see the cases. Case 1. A 68-year-old man with heart failure, previously managed with the furosemide 40 milligram per day. Furosemide is a diuretic generally used as a first-line agents in the management of the hypertension. Digoxin 0.125 milligram per day. Digoxin is a cardiac glycoside and used in the management of the heart failure. Metoprolol is a beta blocker, which is a cardioselective beta blocker. Lisinopril is angiotensin converting enzyme inhibitors. Metoprolol is 50 milligram twice daily, and the lisinopril is 40 milligram per day. He returns for the prescription refill of ibuprofen. So means the patient of the heart failure with the 4 medications: furosemide, which is diuretic; digoxin, the drug which are used in the management of heart failure; metoprolol, beta blocker; and the lisinopril, angiotensin converting enzyme inhibitors. Plus, he has arthritis, and due to arthritis, he uses the ibuprofen 600 milligram 3 times daily, which he takes for his RA, that is rheumatoid arthritis. During the past 2 weeks, he has noted increased leg swelling, weight gain of several pounds, shortness of breath, and easy fatigability. Now, leg swelling, pain, okay. Shortness of breath due to heart failure, fatigability due to heart failure. But weight gain and the swelling indicates the edema. And if it indicates the edema, the furosemide is also used for the management of the edema. What is the reason the patient is on furosemide, still he is getting leg swelling and weight gain? Let us see the questions. Why might these signs and symptoms be associated with ibuprofen use? Because we know that ibuprofen is non-steroidal anti-inflammatory drugs and inhibits the COX in the kidney, decrease the synthesis of renal vasodilating prostaglandins, vasoconstriction of afferent arterioles, which decreases the GFR, which leads to salt and water retention, and that's why edema. So the patients complaining of the leg swelling and weight gain, that is edema, is most probably due to ibuprofen. But we are also using furosemide. Why edema? Because ibuprofen has an antagonist, the vasodilating and diuretic effect of furosemide, and that's why this is edema. Why? Because the ibuprofen. If non-steroidal anti-inflammatory drug therapy is discontinued, what analgesic anti-inflammatory alternatives are available for this patient and justify? As we seen in this case, ibuprofen is responsible for the edema, leg swelling, weight gain, and also antagonistic effect of furosemide. It is best to discontinue the ibuprofen and use other non-steroidal anti-inflammatory drugs. And the best one is Sulindac. Why Sulindac? because Sulindac does not affect the renal vasodilating prostaglandins. And we can say because Sulindac has a renal sparing effect. If we use Sulindac, it relieves the pain of RA, plus it will not cause the edema, does not affect the diuretic effect of furosemide, which was caused by ibuprofen. Next question. How frequently should this patient's renal and liver function be tested during this non-steroidal anti-inflammatory drugs therapy? So, renal function should be tested periodically. Baseline and every week, because the patient has heart failure and there is a great risk for renal ischemia, and liver function should be tested monthly. If this patient was diagnosed with RA 18 months ago and he exhibits no features of poor prognosis and has low disease activity, which DMARDs, or we can say conventional synthetic DMARDs, are most appropriate for him. Now, as we seen, the conventional synthetic DMARDs include methotrexate, leflunomide, hydroxychloroquine, and sulfasalazine. The answer is best to start with methotrexate or leflunomide, as it is advised to start with one of them in most cases of RA. However, in this case, we can use sulfasalazine as no features of poor prognosis and has low disease activity. So instead of methotrexate and the leflunomide, start with the sulfasalazine, because the adverse effect comparison of methotrexate, leflunomide, and sulfasalazine, the adverse effect of sulfasalazine is reported to be low as compared to methotrexate and leflunomide. And in this patient, as there is no features of the poor prognosis and the low disease activity, sulfasalazine will be the best choice. But what is the note? For most patients, methotrexate or leflunomide, MTX means methotrexate and LEF means leflunomide, are chosen initially because of high rate of clinical response for all levels of RA severity, and also in the patients where there is evidence of radiographic evidence of slowing joint erosions. So that's why methotrexate and leflunomide is a good choice. If sulfasalazine were chosen as initial therapy for this patient, when should be therapeutic effect become apparent, and what adverse effect might be anticipated, and how you can minimize and monitor these adverse effects. These all, not only sulfasalazine, but all disease modifying anti-rheumatic drugs, or we can say DMARDs, need 1 to 4 months for the therapeutic effect become apparent. What are the adverse effects of sulfasalazine? Nausea, vomiting, abdominal discomfort, heartburn, headache, dizziness, skin rash, and rarely affect the blood cells, leukopenia, thrombocytopenia, and also hepatitis. How to reduce this adverse effect? How to minimize the adverse effect? Reduce the dose of sulfasalazine near about zero point 0.5 to 1 gram per day, and then increased it 0.5 gram every week to reach 2 to 3 gram per day. It means that start with the lowest dose and increase gradually every week to minimize the adverse effect. And monitor the adverse effect. How can you monitor the adverse effect? By complete blood count, liver function test, and the renal function test. So this was the case 1. Now we will discuss the case 2. A 36-year-old woman has severe prognosis, progressive RA, and not responding sufficiently to methotrexate therapy. Question: mention adverse effect of methotrexate therapy. It includes interstitial pneumonitis, osteoporosis, and chronic active hepatitis and cirrhosis. Methotrexate is also anti-metabolites used in the management of cancer. These are the severe adverse effect. Question 2. How leflunomide, LEF means leflunomide, how this leflunomide be a reasonable consideration for her? So there is a question, would leflunomide be a reasonable consideration for her? Yes. As leflunomide and oral traditional DMARDs, that is similar efficacy to methotrexate, and the onset of benefit of leflunomide is early as 4 weeks. Because what happened, the patient on the methotrexate therapy, but methotrexate therapy not respond, there is a no significance benefit by the methotrexate, then use leflunomide because it will give benefit early as 4 weeks. But what is the problem with the Leprenomide? How should therapy with Leprenomide be initiated in this time? Because remember that the active metabolite of Leprenomide, which is called M1, it is the name of metabolites of Leprenomide. M1, which is responsible for pharmacological activity of Leprenomide. As a result, this Leprenomide should be initiated with loading dose of 100 milligram orally once daily for 3 days to reduce the time to steady state, as T half of the M1 metabolize is too weak. T half, the time required to eliminate 50% of the drug from the body is too weak. That's why the loading dose should be 100 milligram for 3 days. Then after 100 milligram of 3 days, it should be followed by 20 milligram once daily. And if this dose is not tolerated, the dose should be reduced to 10 milligram once daily. Mention the adverse effect of Leprenomide and how would you monitor these adverse effect. The adverse effect includes rash, alopecia, diarrhea, and reversible liver enzyme elevation. How will you monitor? Monitoring adverse effect by baseline liver function test, followed by monthly liver function tests of alanine transaminases for several months. And when ALT results are stable and within normal limits, testing can be performed less frequently. If lab investigation revealed that this patient was hepatitis C positive, do you recommend Leprenomide for her arthritis? Justify? No, because the risk of liver toxicity with the Leprenomide and the need of Leprenomide for the activation by the liver to the M1 active metabolites. As we know that this Leprenomide is responsible for the liver toxic effect, and the liver is important to activate the M1 active metabolites, which is pharmacological active. So we cannot give, if the patient having the hepatitis disease, avoid it. Which drug? Leprenomide. After 2 months of the therapy, patient does not respond to the Leprenomide and the treatment was discontinued, especially because she is beginning to consider starting a family. What precautions must be taken when discontinuing Leprenomide? She wishes to be pregnant, and for pregnancy, what is the protocol to discontinue the Leprenomide? Give her hydroxychloroquine and sulfasalazine because both drugs are safe in the pregnancy. Leprenomide is teratogenic, pregnancy category X, should be contraindicated during pregnancy, and after discontinuation of therapy, up to 2 years may need to elapse before plasma M1 metabolite level. So if the woman is to be pregnant, avoid leflunomide, which is teratogenic, and it needs up to 2 years to eliminate its metabolite from the body. So to remove these M1 metabolites of leflunomide, cholestyramine is recommended for all the women who discontinue leflunomide and who are hoping to become pregnant. What is the role of cholestyramine? After stopping the leflunomide, cholestyramine 8 milligram 3 times a day for 11 days, it will decrease the plasma level of M1 metabolite. Then patient's blood is tested after 14 days to verify the absence of metabolite. And if the plasma M1 metabolites of leflunomide remain greater than 0.02 milligram per liter, another course of cholestyramine should be administered. Plus, you can also use activated charcoal to decrease the plasma M1 level by 50% after 48 hours and can be effective alternative to cholestyramine. So cholestyramine and the activated charcoals are used to eradicate the M1 metabolites of M1 metabolites of the leflunomide, which is a teratogenic, from the body. What is a note? Methotrexate is also teratogenic, should be stopped 3 months prior to the conception in the women, and the start folic acid supplementation is recommended prior to pregnancy in women taking methotrexate. Which are the safe drugs? Both hydroxychloroquine, sulfasalazine, and azathioprine are safe in the pregnancy. Also, tumor necrosis factor alpha inhibitors, that's TNF alpha inhibitors, are safe in the first and second trimester of pregnancy and should be discontinued by third trimester, except certolizumab pegol, which is safe in the third trimester. And non-steroidal anti-inflammatory drugs can be used during the second trimester and until week 30 of gestation. And for the glucocorticoids, use the non-fluorinated glucocorticoids like prednisone, prednisolone, and methylprednisolone, and avoid the use of betamethasone and dexamethasone during pregnancy, because we can use betamethasone and dexamethasone during lung maturity in cases of the premature infants and avoided in the pregnancy. So betamethasone and dexamethasone should be avoided during pregnancy. So which drugs are contraindicated during pregnancy? Methotrexate, leflunomide, tumor necrosis factor alpha should be not used in the third trimester, except certolizumab pegol. NSAIDs can be used during the second trimester and until the week 30 of gestation. And among the glucocorticoids, betamethasone and dexamethasone should be avoided during pregnancy.